It's my great pleasure and honor to introduce our first speaker, Professor Emanuel Krebs from MIT in Boston, Massachusetts. So we know each other for 15 years and longer. And Professor Krebs is a very remarkable person in the sense he was raised and born in Brazil. Then he went to the United States and he did his PhD in Japan. And years ago, I learned that he did his PhD thesis in Japanese. And I was really very much excited about hearing that. Professor Krebs certainly is one of the early pioneers in using and developing mechanical robot systems for application in neurological use in patients with neurological problems. With Neville Hogan and other guys at MIT, they were certainly the very first in bringing this forward 25 or more years ago. I forgot about the precise timing of that. So I couldn't imagine anyone better than Professor Krebs to talk about use of robots, useful or not. Igor, very, very kind that you joined us for today. And I can, Kirsten, I think we can start this video. Thank you.
Thank you. My name is Emanuel Krebs. I'm at MIT Mechanical Engineering Department. And before I start this presentation, I should disclose that I'm one of the co-inventors in several of MIT patents in the space of rehabilitation robotics, and that also I'm one of the founders of Interactive Motion Technologies that I sold it in 2016, and also I'm the founder of 4Motion Robotics. Both companies operate in this space of rehabilitation robotics. So you should take with the appropriate caveats and salt anything that I might be telling you. Now, it's a pleasure and an honor for me to be having this opportunity to talk to you at the WFNR Jubilee. And tell you a little about what we learned in these 25 years and taking a critical look at robot use. But I also would like to point out that this is also the jubilee of the first paper that we publish or that was published in terms of using robots to assist therapy post-stroke. In 1997, myself with my colleagues, Dr. Mindy Eisen, Professor Neville Hogan, Dr. Fletcher McDowell, and Dr. Bruce Volpe, we published in Archives of Neurology the first paper with a clinical trial on the use and the application of robotics in subacute at the Burke Rehabilitation Hospital to treat subacute stroke at the inpatient facility. So it's a pleasure to be here talking in both Jubilees, WFNR, and of the first clinical outcome on the use of robotics post-stroke. And I'll tell you a little, but most of the things that I'll be talking is about the technology that we developed. Starting in 1989, we developed technology to work with the upper limb, with the proximal, shoulder, and elbow, but not only with the shoulder and elbow, but also with the distant limb segments like the wrist and also the hand. Later on, we also developed devices for the lower extremity, and that became known as the MIT Manus Robotic Gym, robots to train the proximal shoulder, elbow, the distal forearm, and wrist and hand. And it's important to keep in mind that since 2010, so over 10 years ago, the different guidelines already give support to the use of this technology post-stroke. So for example, in 2010, the American Heart Association in its guidelines post-stroke had already recommended the use of robotics, at least for the upper extremity. And if we look to what they already were giving us, they were giving us very good classifications. So for the chronic phase, outpatients, we got class 1, which means that the benefit is much, much larger than the risk, and the procedure treatment should be performed. In terms of subacute, there was less data and continue to be less data, but we got still a very good classification, 2A, where the benefits are much larger than the risks. It is reasonable to perform, and there is a recommendation in favor of treating post-stroke with this technology. This was not just the American Heart Association, the VA and the Cochrane review. They all came roughly with the same types of conclusion, that there was space, at least for the upper extremity, to use robotics to try to ameliorate the impairment of patients that had suffered a stroke. In fact, I'll mention two of the studies that were important in supporting these conclusions. One was run by the Veterans Administration, the VA here in the US, and why I was one of the co-authors in the papers that came out with the results. I actually was just in an advisory role, part of the executive board, but the VA run this independently of us. And what the VA did was quite interesting. They look at usual care in the VA system, and they saw that typically post-stroke care for chronic in the VA system meant 3 therapy sessions per week of the upper extremity training. So what we did is that we deliver robotic therapy also 3 times per week. So we would match time in therapy. So both robot therapy and usual care would be having the same kind of number of sessions to be compared. But there is a clear difference between the kind of treatments that we are delivering in usual care of robot therapy. In usual care, typically in a 45-minute session, the therapist would engage the paretic limb perhaps 45 to perhaps 60 times in these 45 minutes, while with the robot therapy, we are delivering over 1,000 movements in the same period. So the VA also wanted to compare the intensity in the session. So we created what became known as the intensive comparison therapy, where we were trying to match not only the time, but the intensity, the number of repetitions, the quantity of movements that were delivered in a therapy session by the therapist. So this study was already quite interesting because beyond comparing robot therapy and usual care, we also have a positive control to try to see how the technology would compare when we were trying to match the intensity in each of the sessions. Now, the trial lasted 36 therapy sessions, which means 12 weeks, 3 times per week. And the VA was interested not only in looking at the end of the intervention at 12 weeks, but they also wanted to see beyond the acquisition if there was retention of the gain. So for 6 months after the intervention was completed, they continue to monitor and evaluate the patients to see if there was retention. Now, in terms of outcomes, the primary outcome was the Fugl-Meyer scale that measures impairment. And the goal there was to see that the robot therapy was superior to the usual care by at least 5 points, which is the minimum clinically important difference for chronic care. And in terms of comparison between the robot therapy and its positive control, the intensive comparison therapy, the goal was to see around 3 points difference. Now, this was a pretty severe population. At admission, most of these patients had 18.9, 19 points in the Fugl-Meyer scale, which maximum for the upper extremity is 66. 1/3 of these patients had had multiple strokes. And in average, it was almost 4.7, almost 5 years in average since their last stroke. So this was quite a severe population. And because it was the veterans of our armed forces, most of them were males. Now, the VA did something quite interesting in the design of this trial. So, of course, patients were randomly assigned to one of the 3 groups, the robot therapy group, the intensive match, and the usual care. But the VA did something quite clever that to try to reduce perhaps attrition in the usual care, they offer at the completion of the usual care period that patients in this group could select either robotherapy or intensive match, their decision. So that would be the enticement to stay to the end of the study in the usual care group. Now, the other thing the VA did is that they adopted an adaptive algorithm. So what they did is that once an intervention wouldn't be like affording new insights and would have like kind of stop improving, they would stop the intervention. So after a year, they stopped collecting data in the usual care group. And as before, the comparisons were 12 weeks, the end of the intervention, and 6 months after the intervention was completed. The results were published in a series of papers, but this one is perhaps the clearest in terms of quantification that the VA did publish, where they show that when they are comparing usual care with robotherapy in terms of the Fugl-Meyer scale, you see that at 12 weeks, the difference was around 4.2 points in the Fugl-Meyer scale between the two groups. And when we compare at 6 months after the intervention had ended, the difference is of the order of 4.6 points in the Fugl-Meyer scale. So that was quite nice to see. And their conclusion was that they found that in chronic stroke population, intensive therapy had significant benefits after 12 weeks of therapy. And although the benefits persisted, the difference were slightly attenuated after the 6 months as compared to the usual care. So they had demonstrated that compared to the usual care, there was a significant benefit for delivering robotic therapy in this study for chronic patients. Now, beyond that, the VA also could run an economic analysis, and it was also very insightful because in the VA system, that's a kind of socialized medicine system, they did see that if they assumed that they were not going to spend any additional dollars in the usual care, they would have, when we consider the cost of buying the robots and also having a therapist assigned to deliver therapy with them, it would cost of the order of $5,000 more per patient to perform the intervention, while the intensive comparison therapy, the positive group, already would cost more. But what was far more interesting, in my personal opinion, was that when they looked to the total healthcare costs, meaning the interventions, the therapy, plus all the other healthcare costs, the expectation was that the robotherapy and the intensive comparison therapy were going to be more expensive than the usual care. This is the total cost, everything that was spent to take care of these patients. But actually, when you subtract, you see first that there wasn't that difference. Robotherapy and intensive comparison were not more expensive than the usual care when you add all the costs. And if you subtract from these interventions the cost of the robotherapy or intensive comparison, you see that these both interventions were actually all the other healthcare costs, excluding the intervention, was much smaller. So that was very interesting, and that was not placebo. Because as it was suggested, perhaps this was placebo. So what we did is that we asked the VA, after the intervention was completed, to keep tracking the cost. And if in this line here on the top, black line represent the cost of the usual care, 19,000. And here we have the intensive comparison, and blue, the robotherapy, all the healthcare costs. When we subtract the interventions, the robotherapy and the intensive comparison, we have these numbers. And the idea is that once the intervention, the attention had ended, if it was placebo, the cost of these active interventions would go up towards the usual care, but they didn't. Intensive comparison went a little up, but actually robotherapy, after the intervention was completed, went even further down perhaps because the patients improved and require less attention. So that was a significant savings for the VA when they compare the total healthcare utilization cost. Now, this was published. Here is just a list of a few of the papers that are summarizing the design of the study, the results, the primary paper on the study, the economics, and also the follow-up where they spell out the actual numbers of it. So those 4 papers summarize this study, the VA study, which was quite important and published more than 10 years ago. But since then, we had continued and then run an even larger study, in this case in the UK, with the support of National Health Service in the UK, that enrolled 770 stroke participants that were screened also either in a robotherapy group or another positive comparison, the enhanced upper limb therapy, and then the usual care. So they all follow a kind of similar design of the VA study to some extent. So we had the active intervention, the robot-assisted training. There was a positive control, the enhanced upper limb therapy, and then the usual care. But there was a few differences. One of the differences is that when we look to the number of patients that you will start to see, is that there was a few differences. And one of them is that the attrition rate in the usual care was almost 25%, meant that 1 in 4 patients did quit the study, and was more than double, or at least double, the attrition on the other 2 active arms, and more than double what the VA had experienced. So perhaps the reason for that, the VA had an attrition rate in the usual care of only 10%, not 25%. And perhaps one of the reasons is that in the VA study, usual care was followed by offering the patients the incentive to stay to the very end. So they then could select what kind of active interventions they would like to. In the case of Rattles, the NHS study, this didn't happen. There was no offering for the usual care as an incentive for them to perhaps stay to the end of it. So therefore, the attrition rate is more than twice the attrition rate in the VA study. So something for us to take in consideration when we make future designs of interventions. So the other thing that was quite interesting is that when we look to the changes from baseline to the completion of the intervention to 6 months follow-up, we first see the attrition rate that I already mentioned, but also we see that all the groups were severely impaired of the order of 18 points at admission. And then at discharge, first they all improved quite significantly. The robotherapy group, for example, improved almost 8.2 points in average from baseline to completion of the intervention, and went even further down. The positive control, the enhanced upper limb therapy, also improved quite significantly of the order of 8.9 points. At the completion of the intervention, and also continue to improve further. The usual care also did improve, and also did improve beyond the minimum clinically important difference. They improved of the order of 6 points from admission to completion. And even though the attrition rate was higher, and therefore we need to be a little careful making direct comparisons of these numbers, we have to account for this attrition rate and comorbidities. The fact is that the usual care did improve significantly in this study, which was quite remarkable. And perhaps because of that, that actually was a very important point to take home also, that was pointed out by our colleagues, Stefano Negrini, Chiara Arienti, and Carlotte Kickens, where they were pointing that the big elephant in the room for all the type of studies that we are doing is that the usual care is normally not well controlled. So we literally let the therapist in the different interventions treat the patients the best way they believe it's appropriate, but in many cases, they might even perhaps be changing what they were intervening. So this is something to take in mind in future studies, perhaps, that we would need to consider. The consideration is that perhaps we need also to be a little more prescriptive in what usual care becomes. Now, another thing that we learned in the Rattles RCT is that we were aiming, and I pointed out that at admission, the Fugl-Meyer was around 18 points, so quite severe population. We were aiming at a moderate to severe arm paresis. Now, one of the things that we did is that when the scales were selected, we selected again for the Fugl-Meyer test, the Fugl-Meyer assessment for the upper limb impairment, but it was selected the ARAT, the Action Research Arm Test, as the primary outcome. Now, the reason for that is that the consensus-based recommendations from the Stroke Recovery and Rehabilitation Roundtable from our colleagues had suggested that this should be the two scales that we should consider. And those were the two scales, with the ARAT being the primary one in Rattles. Now, one of the things that did happen is that when we looked at the results of Rattles, the ARAT was perhaps not the right scale to measure function for this population, because as pointed out, the scale was not very sensitive when we were looking to this population, because the scale primarily depends heavily on hand functions that might not be the right ones to be evaluating in this very severe to moderate population. So the scale essentially didn't have much except an L shape or U shape, pretty much empty in the middle of it. So while something for us to take in consideration is that while the Fugl-Meyer assessment seems to be quite robust in terms of measuring impairment, in terms of function, we haven't yet found perhaps the right one when we are running studies with severe to moderate strokes. Perhaps for mild strokes, it's the appropriate one, but definitely with the 770 stroke patients and the data had shown not to be the right scale for the severe population. When we look to the Fugl-Meyer, I already pointed out how much the patients improve from admission to discharge and to follow up. But interestingly, when we look to the statistics, and here again, the difference from admission to completion was around 8 points for the robotherapy, actually 8.2, 8.9 for the active or positive control, the enhanced upper limb therapy, and around 6 points for the usual care. Quite a strong improvement also. But when we make the comparisons, and here you have to look to the odds ratio, that are these whiskers around the center point, the average, what we see is that for it to be significant, it has all the points of the whisker be on one side of this blue line. And in addition to that, the whiskers need to be including the 5 points to be considered that the improvement might have an impact also in terms of MCID. And what we see at the completion of the intervention is the robotherapy and the enhanced upper limb therapy, the positive control. They both are well into the positive side, and the whiskers do not touch this line, do not cross the zero line, showing that they are beyond, they are statistically significant and also including the MCID range. At 6 months, only the robot therapy maintained these characteristics. If you look here, the enhanced upper limb did cross this blue line, the 0 line, so it's not statistically significant, while the robot therapy still is statistically significant and still including the 5 points MCID. So here is a set of the different publications. The first one is just telling us the design of the study, 2017, the results of the study that came in 2019. And then we have the design of the positive control 21, and also the analysis of the ARAT. There is a 5th paper that I didn't include it here that is talking about the economics, the results in terms of the economics in the RATO study, which was quite nice and very insightful also. So I also recommend that perhaps you have a look at it. Now, we did show that by now, robot therapy has a clear advantage over usual care, at least in terms of impairment. But the question that perhaps we need to answer better in the future, and we believe we have at least a very strong hint, is how to deal also in terms of impairment. Of course, we have to select the right proper scale to evaluate that. But how can we transfer the gains in impairment into function? And one group of colleagues in Taiwan perhaps gave us the best indication of how to do it, where they intersperse robot therapy with training, where the therapist, after so many sessions, would engage the patient and transfer the gains of impairment into function. We took this idea and tested it, and we got the same result. So perhaps this is something to be considered in the future when using this technology, not only using the technology to train and reduce impairment, but also have the therapist then work with the patient to translate the gains into function. And this is what we are representing here, where perhaps something that I heard many years ago by a colleague, Valerie Pomeroy, had pointed out to me that perhaps because we are working with very severe patients, we should use the robots and be exclusively focusing on impairment. And then based how much they improve, have the therapist train the patient to take advantage of the gains in impairment to enhance their functional abilities. And perhaps we suggest that perhaps this might be the right way for us to proceed forward and include this technology. Now, I'm going to try to show 2 things perhaps to convince you of this. This is on 2 reasonably recent papers that we published in terms of looking to the robotic kinematics to measure arm in chronic stroke. And I just want to take from these 2 papers, like the view of patients in the chronic phase, how they would improve. Here is a patient with a Fugl-Meyer admission of 9. And after the 12-week interventions, that person got a Fugl-Meyer of 16. The person is being asked in this non-assisted situation, the patient is asked to make a kind of a star pattern and hit targets that are presented outside here. And here is what the person is able to do at admission. And here you can see what this person is able to do at discharge. So now that person is able to go and, with some difficulty in aiming properly, but the person is able to go and hit all the targets after 12 weeks of training. When we ask them to do things that they didn't train for, like here, draw circles, at the beginning, this is the best they can do. After the 12 weeks, they are starting to draw something that actually resembles a circle. When we ask them to go to the distal and point with their wrist, they can't do much at admission, and they still can't do as much at discharge, but a little more. So this was a patient 9 to 16 When we look to a patient that at admission had a Fugl-Meyer of 15 and discharged 25, we see that from the beginning, the person is able to kind of hit all the targets, but improve much more at discharge when they had the 12 weeks training. They are able to do something that resembles a circle, but it's much better and smooth after the training. And with the distal training, the distal joint, while at the beginning they couldn't do much, at the end they are starting to hit a few targets. Remember, these are unassisted movements. And here you have a patient that at admission had a 24 Fugl-Meyer. So it's able to make pretty decent, it's able to make a nice circle, and can like move a little the wrist, but after training, much better, can hit all the targets quite smoothly, draw a nice circle, and it's starting to be able to point with the wrist in all the directions appropriately. So I think by now, I hope that I had convinced you that these 25 years of testing and development had shown that there is a clear evidence that robots or robotic therapy or robotic assisted therapy work a little for many patients. And I have to say that there is also clear evidence that robotics work a lot for some of the patients, but at least it works a little for most patients. And I would complete here just reading to you this end of the newsletter from one of the patients in the Rattle study in the UK, where he wrote a kind of a poem that was published in the newsletter that Rattles sent to all participants throughout the trial, where he said that he sometimes found that my trial was exhausting. I'm Tom Stephen, not Stephen Austin. And as you can see, I'm not the Iron Man. Although I always do the best that I can, you can see improvements in my score. Don't even mind doing the circles anymore. I think even with resistance, I would push on through. Wendy will say knuckles up or knuckles down. I have my eye on the leaderboard crown. I think my arm is getting stronger. I can do the exercise longer. I also have more control. A full recovery is my goal. I don't have trouble reaching the top of the clock anymore. I'm always trying to improve my score. When I started my trial, the flashing dots of the clock were hard to achieve. Now I learned how to straighten my arm and I can do anything, I believe. I still have a wee bit trouble rotating my wrist. I push or pull when I should twist. For me, the trial was a resounding success, but I wish it lasted longer. I need to stress. So this was like a poem written by one of the participants in the Ratu study. And with that, I'm going to thank you for your attention. And again, thank you for the opportunity to talk in this Jubilee series. Thank you so much.
Okay, Igor, thank you very much for this comprehensive review, especially on upper extremity robots, looking at various aspects. Nevertheless, of course, that's 25 years now, as you mentioned. These were 25 interesting years. We more and more learned to use robots and to embed them in some sense into clinical practice. And let me start with one question. I come to the chat room in a minute. Do you think there is a difference in the application between chronic and acute patients?
This is a very good question. That typically we see that in acute phase, I'll say not acute, I might say subacute. I don't have data in acute, sure. But when we look in subacute phase, patients typically improve even further than what we are seeing chronic phase. So this is quite an interesting observation and point that I should perhaps be clear that if we think about the windows of opportunity, there is the potential that we might get even further impact if we start a little earlier, not just the chronic phase. In the case of rattles, the goal was to have 3 groups, including one subgroup that would be looking at the subacute phase. Unfortunately, when we look to the total numbers of patients, that group was reasonably small, and then we didn't see a statistical significant difference between the improvement in the chronic and the subacute. But that's because the subacute group was very small compared to the chronic one. Okay, but there is an intuition that there will be a much better result if we'll be able to act into the subacute phase.
Well, I think we have to consider that, especially when we look at stroke patients, we are dealing with, let's say, biological problems. One of these is proportional recovery. We know that irrespective of what you do, you have a chance to get better by about 70% of the difference between what can be achieved. And we know that we have critical time windows, which in stroke more or less. That is the same in humans, and it's also in kittens and rats, about 3 months. And therefore, we know that if we want to change the slope of proportional recovery by any means, it is absolutely mandatory to have more intensive treatment. And I think especially at that point, I think robots can come into play because they allow for higher repetition rates and allowing for what human therapists probably cannot do for really a high intensity treatment. I think that is a very important issue. Another point is that in acute patients, especially lower extremity, with that make that point, you can start very early. And in this respect, the robots open new therapeutic windows, which you cannot do by other means. That is, especially when it comes to gait training, it's basically impossible to do that by conventional means. Okay, there are some questions in the question answer. One very interesting question to Professor Krabs is about the novelty effect. The novelty effect, of course, is always an effect that could be considered when new technologies are coming in. Igor, do you think that the novelty affects that you're doing something uncommon in some sense, which patients have not known before?
I can try to answer this in 2 different ways. The first one is to say that, of course, attention is very important. So during the delivering of robotic therapy, one of the key aspects is to engage the patient and have them actively participate into it. The second way to try to look to this is to say, beyond that, is this just a placebo effect? So there are 2 ways that you could look to the question. The first one is saying, of course, we want to engage the patient. We want to have the novelty, and not only have the novelty in a single 1 or 2 sessions, but they take that window of opportunity and catch, I would use the word catch, the attention of the patient so they continue to engage during therapy as best as they can. But the results that we are obtaining or the improvements that we are obtaining are something that is able to maintain and be sustained, and it's not just a placebo effect. So I want to point this in the 2 directions because it's a little unclear where you were trying to refer to, but we did show in the VA that is not placebo, but attention is critical for this type of interventions. We did a study where we used the robots as a continuous passive motion machine, actually 2, one with children and one with adults, where the patients were not participating. They were seeing TV while the robot was moving their limb around, and that had very little impact in the improvement as compared to the group that was paying attention improved significantly more than the one that was not.
Okay, well, novelty effects certainly are of importance as they may boost up motivation to some extent in the early phase, but you're treating patients for a long time, and usually that melts away and habituates within a couple of days. So the novelty effect as such cannot be the sole explanation. I think there's another question, I think, which is interesting. We have discussed this problem, robotics and tone disorders quite a lot. And Oliver Kaut is asking, can we use robotics in movement disorders, for instance, in Parkinson's disease, to reduce rigidity?
There are some studies that had shown that if you move the limb segment repeatedly, you can definitely reduce short-term the tone. I do not know if that is a lasting effect. So I don't have data to answer this question. So I would go in and here claim the fifth, which means I'm not going to try to answer what I don't know.
That's right. That's always a good idea. Nevertheless, I think there is certainly a problem with tone disorders, especially in gait robots, for instance, if patients really have persistent severe spasticity, especially during spasms, that can be a difficulty. And of course, I think passive movement may reduce tone problems. But nevertheless, for this, you can use just cheaper machinery than robotics. That's for sure. Okay, so let me have a look if there are any further questions. May welcome Professor Sukadar, who has joined us in the meantime. Any questions, sorry, from your side?
No, no questions from my side.
No questions from your side. Okay, so then I have an empty question box. And Ego, thank you very, very much again for joining us. You stay with us. We will have a general discussion at the end. And it's my delicate pleasure to introduce the next speaker, which is Professor Surya Sukadar. He is the Albert Einstein Professor of Clinical Neurotechnology at the Department, believe it or not, of Psychiatry and at the University of Berlin. Professor Sukadar was originally trained in psychiatry as well as neurology. And during his early, let's say, studies as early residencies, he already started to get an interest in neurotechnological aspects. He was with Leo Cohen at NIH, and he did his thesis with Hatta Floor in Mannheim, as far as I remember, on phantom limb problems. And later on, he was also working with Niels Birbaumer, who was certainly one of the pioneers of brain-computer interfaces. And Surya certainly is one of the most, let's say, renowned person in the field of brain-computer interfaces. And therefore, we are very great to have him with us today for this webinar. And he's going to talk about applicability of brain-computer interfaces. Thank you very much for joining us. It's a great pleasure to have you with us today.
Well, the pleasure is all mine. And as this is a pre-recorded talk, I would invite you to write down the questions if you have any. Since I pre-recorded, all the ams and ohms were cut out. So the talk is only 21 minutes. And this gives us a little bit more time to discuss and maybe also go into newer ideas like the synchron approach, intravascular BCI, and how realistic that is to really implement that. So if, well, I think
we start the video.
Exactly.
Divided into two sections. In the first section, I will provide an overview of the state-of-the-art in brain-computer or brain-machine interfacing. In the second part, I will try to answer the question whether BMIs are ready or not for neurorehabilitation. Brain-computer interfaces, or BCI, are defined as tools that translate electric, magnetic, or metabolic brain activity into control signals of digital devices. These can be robots, drones, or computers. The most common brain activity recording techniques that are used for BCI include electro- or magnetoencephalography. Another very promising avenue in non-invasive BCI research is the use of optically pumped magnetometers that can measure neuromagnetic activity at room temperature. Also, these sensors are wearable. So these new quantum sensors theoretically allow to non-invasively record brain activity at unprecedented spatial resolution due to their proximity to the cortical surface. The main disadvantage with this technology is currently that it requires a shielded room to block environmental electromagnetic fields. Novel technologies, for example nitrogen vacancy magnetometers, may overcome this challenge in the future. Other non-invasive tools also include functional near-infrared spectroscopy, shown here, the upper right, and functional magnetic resonance imaging. So in functional near-infrared spectroscopy, the surface layers of the cortex are assessed and blood oxygenization evaluated. In functional magnetic resonance imaging, also deeper areas of the brain can be assessed, for example in the thalamus. Then there are the invasive approaches, such as electrocorticography or single or multi-unit recordings using microelectrodes. Here the Utah array with 96 electrodes on the lower right has set an important standard, and there are now other approaches developed, for example by Neuralink, that scale up to 3,000 electrodes implanted by a special robotic device. Currently, only the Utah array has the FDA approval. Only very recently, Neuralink released more information about their new device, the Link. Being of the size of a €2 coin, the device is fully implantable and can be inductively charged. For implantation, a special robot is used that can perform the implantation within 1 hour. The robot automatically detects blood vessels and adapts the implantations accordingly. Here you see the implantation procedure that reminds a bit of a sewing machine at work. The device was implanted in several pigs, and Neuralink claims that they could successfully decode various joint angles based on the neural activity that was recorded. Although in a very early stage, it is quite impressive what was achieved in such a short time. It can be expected that the first clinical use of this device in a person with severe paralysis will be just a matter of 1 or 2 years. Let's come back for a moment to the beginnings of BCI. The first clinically meaningful BCI was introduced by Niels Bierbaumer in the late 90s. Niels Bierbaumer enabled a patient who suffered from locked-in syndrome due to ALS to select single letters on the screen to write a letter using his electric brain activity. This letter was published in Nature and generated a considerable wave of enthusiasm for the clinical use of BCI for restoration of communication. Besides restoration of communication, also restoration of movements was achieved using BCI technology. Here you can see a number of demonstrations where a monkey or a person with severe paralysis, for example due to brainstem stroke, are able to drive a robotic arm that assists in eating or drinking. Using 3 Utah arrays, even 2 prosthetic devices could be controlled simultaneously. And this patient did not only see and feel the touch of the objects, but at the same time his cortex was also electrically stimulated. So that was a bidirectional brain-computer interface. A less invasive approach uses electrocorticography. Here you see a novel system developed by Benabit and his group in Grenoble. They removed a piece of the bone and implanted a device that allows for recording ECOG from motor areas. The device was implanted in a quadriplegic young man with a cervical spinal cord injury. Here you see how the young man can control a whole body exoskeleton using this implantable BMI. The user could also perform various reaching movements that increased in precision over time. So you see how he's trying to reach this object that is lit up with a green light, and after quite some attempts, the patient can reach the goal. Now, the problem with implantation of brain-computer interfaces is that there is the risk of bleedings and infections. There is no certification for permanent use, and none of these patients have used the system outside of the laboratory in their daily life. Moreover, removal or repair of such device also requires a surgical procedure. Therefore, together with my team, we have developed a completely non-invasive approach that uses electroencephalography and electrooculography to restore grasp function. Here you see several patients with severe finger paralysis due to a high spinal cord injury. As you can see, they have a hard time to grasp any of these different objects of daily life, for example, a cup or a book. We have equipped these patients with a brain neural hand exoskeleton that translates their intention to move into actual hand movements driven by the exoskeleton. And with this system, they were able to securely grasp and manipulate these different objects. Importantly, the system could be also used outside of the laboratory, for example, in an outside restaurant. The patients could leave the lab and eat and drink independently. We have asked the patients what they would like to do with their new ability, and this patient asked for a plate of potato chips. So here you see how this device really can have an impact on the quality of life in paralysis. We have extended the setup towards neural control of whole arm exoskeletons because many patients have lack of shoulder and elbow movements. The critical advancement here was the involvement of AI-based robotics that allow the system to localize and identify different objects, such as a bottle or a cup, and move it to the patient's mouth. The BCI system was also used in chronic stroke patients who were unable to move the fingers, sometimes for many years or decades. When these stroke patients used the neural exoskeleton repeatedly over a time of maybe 1 month, we found something very surprising. Some of the patients were able to move the fingers even without the exoskeleton. Using fMRI and DTI that you see now here on the screen, we found that their brains have reorganized and rewired. While there was a bilateral activation before the training, shown on the upper row, when the patients tried to move the paralyzed fingers, after 1 month of training, the activity shifted to the ipsilesional hemisphere. This cortical reorganization correlated with a clear clinical improvement of hand and finger function. This means that the brain-computer interface can not only be used as an assistive device, but also as a rehabilitation device, even in patients with severe chronic stroke. Many other groups corroborated this finding, and there is now ample evidence that repeated BMI use to control an exoskeleton can result in relateralization of brain activity and restoration of EMG activity in the paralyzed limb. So here you see the cortical map and representation of the attempt to move the paralyzed fingers, and you can see that there is a focusing and relateralization to the areas that are connected to the exoskeleton. And with this paradigm, after a certain time, there was an increase of decodable EMG activity in the paralyzed muscles. The same finding was also shown for the lower limb in spinal cord injury. Here you see a young patient who trained to control basic gait movements using a brain-machine interface. After 9 months of training, the patient was able to move his legs and also restored some sensory function. After 13 months of training, the patient was able to elicit some basic locomotion movements. These studies exemplify the vast potential of brain-computer interfaces to trigger neurological recovery. Provided high temporal and spatial resolution of the intervention, efficacy of such approach can be remarkable. Here you see a rat that received a complete spinal cord lesion. By recording brain activity and translating this activity into stimulation of the spinal cord, the rat was able to move again. The same principle was also implemented in a human with SCI. However, the intention to walk was not decoded from the brain, but from trunk EMG. So here you see how the patient receives the stimulation while he tries to move. And when the stimulation is turned off, you see that the patient is not able to continue walking. And turning the stimulation on, the patient can continue walking. Now, after several weeks of training, the patient was able to move his legs, and a few months later, he could even walk unassisted. Meanwhile, there are hundreds of patients who underwent BMI training or other neurotechnological interventions. A recent review by Koska nicely shows that the minimal mean difference in upper limb Vogel-Meyer scores was highest with BMI compared to other interventions and reached up to 13.2 points. The review also shows that there is great variability in efficacy across study participants. So Friedhelm Hummel and his group rightly come to the conclusion that in order for neurotechnology to work, patients have to be stratified and treatments personalized to improve outcome. Right now, it is not entirely clear which biomarkers are most specific or predictive, but measures of corticospinal tract integrity, for example motor evoked potentials, are very promising candidates for stratification. Obviously, use of a brain-machine interface with an exoskeleton is most reasonable in patients without any functional movements. Here we have introduced a possible pipeline of treatment steps after severe stroke. In patients who present with very limited hand function, a brain-machine interface could be used to restore decodable EMG activity. This activity could be used either for exoskeleton control or functional electric stimulation. Finally, once basic motor function is restored, constraint-induced movement therapy would follow. Let's summarize the first part. I have shown that assistive and restorative brain-machine interfaces are effective clinical tools to improve living conditions in paralysis. I have also shown that repeated use of BMI technology can lead to functional and structural plasticity of neural circuits and trigger neurostimulation. However, the variability in clinical efficacy is very high. Instead of a one-fits-all approach, stratification and personalization are key. So, is BMI technology now ready for neurorehabilitation or not? Let's come now to the second part of my presentation. What are the biggest challenges in introducing brain-machine interfaces in routine clinical care? So I have pointed out that proper stratification would be necessary, but at the same time it may be also very cost-intensive, and diagnostic tools like a TMS, fMRI or DTI may not be available everywhere. Also, treating paralysis with a brain-machine interface over several weeks without the perspective of recovery may be economically problematic. So, BMI-related sensory feedback without functional meaning, for example visual or vibrotactile feedback, may not be sufficiently motivating over several weeks. A possible solution to address these points is using a neural exoskeleton as a technical aid in physiotherapy and for practice of activities of daily livings at home. And to make this point, I would like to go a little bit deeper into this area. Here you see a patient who tries to open a bottle with her spastic hand. We asked the same patient to use a neural hand exoskeleton that allowed her to securely grasp the bottle and also manipulate the bottle, which would not be possible with the spastic hand. Here is a second demonstration of how this patient tries to open a bag of potato chips. You can see how difficult it is with a spastic hand. She's unable to perform this task. Now with the neural exoskeleton, the patient is now able to perform this task. A more advanced version of the exoskeleton is shown here. So we have connected this exoskeleton with our neural interface, and you can see that the patient who suffers from multiple sclerosis and who was unable to grasp anything with his right hand can now do bimanual activities. And here on the right you see a patient who suffered from a plexus evulsion, who can now grasp these objects with very high precision and place them to a different area. Now, the next big step, of course, is advancing this technology for everyday life environments. We now work on hybrid solutions that combine assistive and restorative dimensions of neural exoskeletons. Here you see a 3D printed, lightweight device that includes a variety of sensors and vibrotactile elements to provide assistance to stroke patients in their daily life. Our hope is that this device will also allow us to study BCI-related functional and structural reorganization of the brain and spinal cord. Now, what I wanted to also show here is a new headset that was designed for patients who have one unaffected side. So this headset can be put on by the patients with one hand and provides signal quality on a very high level using dry electrodes. So the electrode caps in the future will probably disappear because these caps cannot be used by the patients independently. So we will see a replacement of these caps using something like headsets. Now let's come back to the original question. Are BMIs ready for neurorehabilitation or not? My personal answer is yes, but how they integrate and scale up in the near future will depend on early adopters and their willingness to contribute to this process. Right now, there are still a number of technical challenges that have to be mastered. For example, robustness, wearing comfort, user-friendliness, safety, practicality, adaptability, and versatility. But these technical challenges can and will be solved in the near future. At the same time, there are also a number of challenges in the medical care supply infrastructure. For example, reimbursement, training of therapists, integration in existing treatment protocols, and implementation at the caregiving facility. If you belong to the early adopters and would like to implement this technology at your facility, please contact me. We are currently planning to roll out the first prototype for the next year and look for early adopters. Now, when neural exoskeletons are scaled up and brought into daily life, there are a number of neuroethical aspects that need to be considered. These include, for example, data security, privacy, but also accountability and responsibility. Together with some colleagues who also work on implantable brain-computer interfaces, we have identified the most pressing challenges. These issues have to be taken very seriously as technology progresses. Another topic that is very important is neuroliteracy. Neurotechnology is now speeding up like the internet in the late 1980s. It is very important that people in healthcare become more knowledgeable about neurotech and the brain. Now, let me come to the final conclusions before we start the discussion. First of all, assistive and restorative BMIs are effective clinical tools for restoration of movement. There are many novel tools in the pipeline, but the clinical translation still remains a challenge. Using neural exoskeletons as a technical aid in physiotherapy may be the best angle to broaden brain-machine interface use. Brain-machine interfaces for neurorehabilitation is ready, but still depend on institutional support. With this, I would like to thank you very much for your attention, and I'm looking forward to the discussion. Thank you very much.
Yeah, okay, so thank you very much for this very nice review of what is eventually possible, what is ready at the moment. And concerning the early adoption, I think it's a very important issue. And all of the audience, of course, are invited to join you on this endeavor. We have already done, but others may follow. Let me look at the chat room. There are no new questions at the moment. One question from my side. Certainly, there are two different scenarios. One is a neuroprosthetic scenario, in the sense that you use the brain-machine interface to control some sort of helping device, maybe an exoskeleton, what have you. And the other, which goes a little bit further, probably is to use the brain-computer, brain-machine interfacing to help the brain reorganize itself up to a point where you don't need the aiding device anymore. The question for the second part of this is there any clear evidence that this, let's say, reawakening loop is working or not?
It's, of course, an excellent question. And right now, the underlying mechanisms of BCI-triggered neuro recovery is not really known. And that has something also to do with the fact that when you are engaging in some form of a neurofeedback approach, causality becomes really difficult, because to regulate this area in the brain that you use as an output signal for example, an exoskeleton, of course, this regulation depends on other brain areas. And then, of course, you can't say, well, this signal that you are using for the BCI control itself is causally related to recovery, for example, but because it could be a network. And to investigate that, of course, it would be important to directly interact with this network. And we are working on this question with closed loop brain stimulation. So we would like to probe how important certain oscillatory activities in the brain are for the rehabilitation process. But that's exactly the big question here. And here there are really these two hearts in my chest, where I would say, well, from an academic point of view, it's important to understand these mechanisms, and we are doing all what we can to better understand that. On the other side, what really put me to a point where I said, well, we need to scale up this technology now is that when these stroke patients, who were most of the time suffering from severe paralysis, so they had no mean to move their fingers, when these people engaged with a BCI, when their intention to move these paralyzed fingers really led to some form of a reaction of their paralyzed hand, they were so happy about it, and they were very motivated to use this system. And if it has some assistive value, then this already, contributes to self-efficacy, perspective, and also improvement of course, quality of life, because then they can say, I can use both of my hands, I can use this ability now in the physiotherapy. And also physiotherapists were really excited about this possibility, because if you can't really train with the affected hand, that limits, of course, also the range of activities you can do with physiotherapists. So that brought me to a point where I said, well, we need to scale this up. It's a very valuable approach. And it will allow us also to investigate the actual underlying mechanisms of recovery. Because, of course, if you, for example, train with a hand exoskeleton and you move the whole arm, you are training the arm. Yeah, so that's also something that takes place. So we have to investigate that more. But what could be better than having larger studies where we actually apply this technology?
I think that's pretty certain. Let me ask a question for a psychiatrist in some sense. We have these embodiment concepts, okay? And the question is the use of exoskeletons under brain control by brain-machine interfaces. Do they reach a level of a new, let's say, conception framework of embodiment in these?
Yes. They definitely do. So whenever there is some model in yourself that's somehow linked to some effect in your environment, then this model, of course, gets updated. And the only question is contingency and consistency. So if your intention to move some device, and we see that also, for example, in the VR, and that's in the next talk. So whenever you use something that links, your intention to change something in your environment, and you actually see this change environment, there is some update of this inner model. So, and that's probably also what plays an important role in rehabilitation, that this inner model is updated and trained. So I would definitely say yes. The question is then, how conscious is that? So that's also a very interesting question, because when you operantly condition neurons in the motor cortex, and you don't tell the people about a strategy, you just tell them, okay, try to move this thing. No matter how, they find a strategy. And then if you ask them, how did you do it? They say, I just did it. I just wanted to do it, and it just happened. So they have no explicit insight into how they actually regulate these neurons.
Well, I just look at there's one question from the audience alluding to the point: are these arrangements for training of caregivers necessary, especially physiotherapists, if they want to use that? Probably yes.
Yes. So, well, when we started, it took probably 20 to 30 minutes to mount the whole system, and that, of course, has changed dramatically in the last 10 years, I would say. So now our system can be mounted within 2 minutes, and it can be calibrated within 7 to 10 minutes. It has to be calibrated to see. It has to be calibrated at the beginning for the control. But at that time already, the patient gets feedback, and then you can start with the training. And of course, to do that, the person, the caregiver, has to be trained. But the training is really easy. Yeah, it's not rocket science anymore. So that's also something that we are working on. So the idea is really to go into something that is broadly applicable. So we need something that can be controlled with a smartphone app or something really simple where you just press start and stop.
It's getting simpler and simpler and more easy to use. We have a widespread international audience ranging from India over Nigeria to Finland. And there's a question, however, from Oliver Kaut, he's from Germany. Do we have limitations regarding the age of a patient? Is there a max age by the age of 60, or is there any age restriction?
No, there should be also no restriction. I mean, if we do clinical studies, of course, we need to somehow homogenize the population, and then it makes sense maybe to cut it, I don't know, maybe 70 years, because then you have a lot of comorbidities and it becomes really almost impossible to have a homogeneous population. But if it comes to the actual application where you are not comparing patient to patient, then there is no limitation. You can also use it with 90 years old.
Okay. Well, I have a difficult question for you, which is somewhere at the edge between philosophy, ethics, and all of this. You know, people as Ray Kurzweil and others have very much stressed the idea of a singularity step that would change the human mind and expand the human mind by using implanted or whatever devices. Elon Musk is very much also behind that with the Neuralink system which you mentioned. Do you think that there is a real risk in doing that, in the sense that the more you approach the brain directly and you're more or less able to read the human mind, if you like, was phrasing, which is probably not very appropriate, but read the human mind, that there are potential risks in that?
Well, that's also an excellent question. So right now, with the BCIs, especially with the non-invasive BCIs, this kind of risk is extremely limited. Now, if it comes to implantable BCIs, and we've seen the Utah array for the last 2 decades implanted in humans, of course, the number of electrodes is limited, and we could do really some extremely helpful basic research with this device. Now, there is this assumption that you just have to increase the number of recording electrodes and then you can do magic. The problem is that this hasn't really been suggested by the data. So there is a lot of redundant information in the cortical recordings. So another problem is also the non-stability of representations. So you were mentioning this inner model. I mean, this inner model is somehow embedded in this activity, and it is dynamically changed. And it was very impressive that, you know, when you implant this Utah array and you operantly condition these neurons to control a robotic arm, the performance wasn't really stable from day to day. So you would see some learning curve, and we see this learning curve also in non-invasive recordings, but you could not really rely on it from day to day. So it could be a day where this just wouldn't work so well. And there was a very nice study now from Niels Bierbaumer, his last publication, because he said he's retired now. So, really? So if you've seen it, maybe in Nature Communications, it just came out a few weeks ago on a patient in complete locked in who received a Utah array. And the thing is, there also the communication rate with this locked-in patient, complete locked-in patient, was something between 100 and 400 words per day. And he would use this for several hours a day. So it was extremely slow, much, much slower than in healthy volunteers. And it was very variable. So some days he didn't even know why it was working better, but he could just spell 400 words. So the problem is we haven't really understood why this variability comes into the place. And well, there are so many things that we have to answer and understand first before we can really speculate about singularity with the brain, because we don't even know how the brain integrates information. This hasn't been, I mean, usually when you open the textbook, you think, well, it sounds like a computer and the cell is computing. But actually, we don't really understand where the information is integrated. And well, once we have understood that, maybe we can estimate what would be needed to really link a computer with a brain. But right now, the link is operant conditioning, and it's a basic biologic principle. It's not clear how other mechanisms can be really used for this kind of brain-computer communication.
So we are still safe.
Yes.
We're not running the risk of abuse and misuse.
Yes, but what I would definitely say is, and that's something that you can already see now in other fields, when you are contributing your data, you, for example, through Google searches, and maybe you have an Oura Ring, or you have a cell phone, and everything is somehow tracked. Of course, it's possible with computers and very powerful computers to correlate. And that is exactly what happened also in a study with an ECOG grid, where this Jennifer Aniston neuron was detected. So if you have these recordings from from neurons or from biological signals, you can correlate them with some context. And of course, the more information you have, the more you can also read and interpret. And that's something that people need to be aware about. It's not only about their brain, it's about all the data that they are actually surrendering to other parties. And that's something where I think we need to tell the people about it. And if we do this properly, then the question whether you would actually use a brain-computer interface to use Facebook maybe becomes a bit more reflected.
Thank you. I was reminded by a colleague from the UK that also UK participants are there. I mentioned that now officially. And okay, I think there, as far as I can see at the moment, there are no further burning questions to Professor Sukadar. So, sir, thank you very, very much indeed. I think that was a really brilliant tour through the problems of BMIs. And we go on for the next talk. And it's my pleasure to introduce a very young scientist. WFNR is very much behind the idea of having more young clinicians joining us and helping with their careers and do some sort of facilitating this. Lucas Lorenz is a psychologist by training, and he did his master's at the University of Maastricht in the Netherlands, and he is now enrolled for some while in a common project we're running with also with other European groups. And he developed an interest in the applicability of virtual reality, especially in psychological domains and cognitive. And I asked him to give sort of review about the usability and applicability of VR and AR technologies. So, look, thank you very much for joining us. And
thank you very much for this opportunity.
Okay, Christian, you can start the video, I think. Yeah.
And welcome to this presentation on virtual reality and augmented reality in rehabilitation. My name is Lucas Lorenz, and I work as a doctoral student at the St. Mauritius Therapie Clinic in Meerbusch, Germany, where I conduct mostly studies on virtual reality and cognitive rehabilitation. This is therefore going to be the focus of this presentation. However, I also want to address other fields of rehabilitation and at the very end mention a domain in which I think augmented reality is likely to play a major role in the future of rehabilitation. So to start, I'd like to introduce everybody who's completely new to this topic to the terms virtual reality and augmented reality so that we're all on the same page. VR refers to a technology in which the user wears a head-mounted display that covers his entire visual field and shields him from any external stimulation. His head and hand movements are tracked by sensors and can then be represented in the virtual environment, while the image of his surroundings is rendered slightly differently for each of his eyes in order to create an illusion of depth. All of this adds up to a sense of embodiment and leads to the experience of immersion, the feeling of actually being in a virtual environment while forgetting one's real surroundings almost completely. On the other hand, we have augmented reality. This technology is mostly used on mobile phones and tablets. Here the user sees his actual environment, usually through a camera lens, and then virtual objects are merely added into the scenario. Prominent examples include Instagram filters, deepfake technology, which some of you might know from recent movies, games like Pokemon Go that made very prominent use of augmented reality, and some other devices like the Google Glasses or the HoloLens, and there's also a lot more similar devices on the near horizon. Virtual reality and augmented reality are often mentioned within the same breath because they can be placed under the umbrella term of extended reality. These technologies aim to integrate elements of the real world with digital elements and merge them into one holistic experience. Extended reality technologies can therefore be placed on a spectrum, ranging from complete virtuality to complete reality, with virtual reality being closer to the former, since one almost exclusively interacts with virtual content, and AR near the latter, since here only some objects are virtual. I want to first go back to virtual reality. The technology of VR has been developed in the early 90s and improving ever since. However, since big companies like Meta, formerly known as Facebook, have entered the VR headset market, the technology has made big leaps in terms of performance, user-friendliness, and accessibility. VR headsets are also becoming a lot cheaper in recent years, all leading to VR becoming more and more visible in popular culture. VR is mostly known for video gaming. However, it is also increasingly used for simulation trainings for surgeons, pilots and firefighters, and policemen. Basically everywhere where potentially dangerous situations need to be practiced repeatedly. We also find it applied in architecture and design more and more, since it has become fairly easy and cheap to create very vivid 3D presentations of any imaginable object. This, of course, has also inspired artists to become interested in this new medium and explore the new possibilities of this technology. However, what we're interested in is the application of virtual reality in medicine. As shown in this graph from a review from 2021, publications about virtual reality have been rising almost exponentially over the last 30 years. This trend is likely to have continued during the COVID pandemic, in which healthcare professionals all over the world were forced to think about virtual remote therapy, and with recent announcement that the so-called metaverse is going to play a major role in the future of one of the world's most influential companies, VR is likely to become even more relevant in the following years. As of today, virtual reality is already in use in several domains of healthcare, which I have grouped under motor rehabilitation, exposure therapy for anxiety disorders and phobias, pain management, and neuropsychological rehabilitation, meaning disorders of perception, memory, and cognition. And I want to go through each and every one of them because they make very different. They make use of very different advantages of virtual reality. For example, in motor rehabilitation, VR is mostly used to gamify the training experience. That means that game-like elements are added into the scenario, therefore embedding the repetitive and sometimes monotonous movements of the upper limbs into a context in which they are immediately meaningful and rewarding. Reviews have shown that therapies making use of virtual reality for upper limb rehabilitation were at least equally effective and sometimes even slightly superior to conventional therapies without VR. This effect seems to be brought about by an increase in motivation through gamification, which can in turn positively affect compliance and adherence and overall treatment outcome. In exposure therapy, VR is used for its ability to virtually represent fear-evoking stimuli very vividly. Here we see a patient confronting her fear of heights in virtual reality. The effects of VR-based exposure therapy have been most studied in specific phobias, especially for fear of flying and fear of heights, with some studies indicating that virtual reality treatment was even preferred by some patients compared to in vivo treatment, and showed reportedly lower dropout rates. Advances have also been made to target more abstract fears, like for example social anxiety disorder and PTBS. These studies have thus far shown promising results as well. Pain management uses virtual reality for a sense of immersion, in order to distract patients from acutely painful procedures happening in the real world. In a very prominent study, burn victims were distracted with the use of VR while the bandages were renewed, which is very painful. Patients reported significantly lower ratings of pain. Recent reviews have confirmed these effects for children and adults alike with regards to all sorts of pain and even injection anxiety. Applications that target chronic pain, like for example lower back pain, have yielded more variable results, showing that more research is still needed in this area. In the field of neuropsychology, VR has found more than one application. In the diagnosis of neglect, for example, VR applications have been shown to detect forms of neglect with higher sensitivity and specificity than conventional paper and pencil approaches, such as, for example, the NET. This is due to the fact that by tracking head and in some devices even eye movement, a differentiation can be made between the field of perception, which is basically the visual field, and the field of regard or field of attention. VR therefore allows us to gather very detailed information on how a patient with neglect is exploring his visual environment and also taking into account compensatory movements. In cognitive rehabilitation, VR is used to bridge the trade-off between naturalistic real-life conditions and, on the other hand, lab-like conditions. Neuropsychologists need to rely heavily on standardized assessment and therapy situations in order to make sense of their patient's cognitive performance in relation to previous testings and to the population at large. This, however, comes at the cost of these situations bearing very small resemblance to any real-life circumstances that are actually relevant to the patient, like, for example, the reacquisition of his driver's license or picking up the work of his previous job, or other issues that relate to his participation in everyday life activities. Previous studies have shown that the transfer of improvements acquired in a standardized lab-like environment to real-life circumstances is sometimes limited. VR can serve here and combine the best of both approaches by offering virtual scenarios which are close to everyday life, like studying in school or going shopping in a supermarket, etc., while at the same time being completely standardized, safe and controllable since they are virtually constructed. This might facilitate transfer to everyday life and enhance patients' motivation to train. One of the very first applications designed for the assessment of cognitive function was the VR classroom. In this assessment tool, patients had to do a continuous performance task, CPT, measuring selective and sustained attention while they were immersed in a virtual classroom environment. The degree to which distractions like a classmate talking or the classroom door opening could be manipulated by the researchers. In this study from 2007, a group of children with attention deficit hyperactivity disorder, ADHD, and another group of healthy controls completed the VR classroom task, once without and once with distractions. As expected, the ADHD group showed significantly more errors of omission and commission, but the researchers could also show that this difference was even exaggerated when distractions entered the scenario, which could not be assessed by means of conventional assessment. Also, they found that the ADHD group displayed overall more head movement. The findings of the VR classroom have been replicated many times since then, leading a review from 2018 to conclude that the VR classroom can be established as a valid and naturalistic assessment tool for attention deficits. When it comes to therapy, a lot less research has been done up to this point. One example from 2020 used the VR classroom as an intervention for children with ADHD. Patients completed a 12-session intervention of 30 minutes each, in which they conducted the VR classroom task over and over again. A different group of patients received pharmacological treatment with methylphenidate, and another group received solely psychotherapy. The results showed that the VR group and the pharmacological group displayed similar improvements in attentional functioning, while the group with psychotherapy did not improve their performance. However, it should be noted that the outcome measure for this study was the CPT, the very task that patients in the VR group were training over and over again. The findings therefore need to be taken with a grain of salt. The current state of evidence suggests that VR applications have been established as a valid and especially ecologically valid assessment tool for cognitive functions. However, when it comes to VR and cognitive trainings, conclusive evidence is still missing. The evidence suggests that VR applications might at least be equally effective as computerized trainings. However, the generalization of training effects to everyday life is still something where more research is needed. To sum up, VR can provide several opportunities and advantages in rehabilitation. With its ability to gamify the training experience, it can increase patients' motivation to train, leading to higher rates of compliance and adherence, which also increases overall treatment outcome. Its ability to immerse people can be used to distract patients from painful procedures in the real world, or to confront them with their fears in a vivid, yet completely safe environment. Furthermore, VR can be used to adapt the training environment, making it more and more resemble real-life situations, which raises ecological validity and could in turn facilitate generalization to activities of daily living. However, on this point, still more research is needed. But what are the potential disadvantages and dangers of virtual reality? Most rehabilitation work includes elderly people. How do they respond to this high-tech approach when many of them don't even use a smartphone? Also, a question that frequently comes up is the tolerability of VR applications. Cyber, motion, or simulator sickness is a condition that can arise after exposure to VR and can lead to nausea, vertigo, and vomiting. Research in the last years has focused on this topic and identified several factors that have an influence on the experience of cyber sickness. The feeling of vertigo is caused by a mismatch between visual information coming from the VR headset and the vestibular system. It can therefore be avoided by reducing the degree to which this mismatch is going on, for example, by using teleportation to get around in VR, rather than moving the virtual avatar with a joystick, while the actual user remains immobile. Also, the quality of the graphics and the frame rate can affect cyber sickness, thereby making cyber sickness less and less likely in newer VR headsets devices. The duration of the VR experience, as well as previous experience with VR, can also have an effect. In a study from 2021, we wanted to address the problem of acceptance by elderly people and tolerability. We therefore used a self-constructed VR-based attention training called VR Traveler, which targets tonic alertness and selective attention while the player is transported to different places around the world. 35 patients with neurological damage and resulting attentional deficits were recruited from the St. Mauritius Therapieklinik in Meerbusch and the SRH Gesundheitszentrum Bad Wimpfen. Patients' age ranged from 13 to 81, with 51 being the mean. All participants trained with the VR Traveler for approximately 30 minutes and were then instructed to fill in a questionnaire rating their user experience and whether they experienced any symptoms of motion sickness. As can be seen in this graph, participants rated the VR experience rather high with regards to attractiveness, stimulation, and novelty. The ratings in the domain perspicuity, efficiency, and dependability, however, still left something to be desired. This was probably due to the fact that the prototype was not yet optimized for user-friendliness and had some rather clunky handling and technical issues. We did not find any main effect of age on these variables, indicating that the elderly people did not feel differently towards the program compared to younger people. This might be due to the fact that the sense of embodiment felt in VR might actually come more naturally to people who do not have a lot of experience with high-tech devices. When we looked on the VR, how the VR program was tolerated by patients, measured with the virtual reality sickness questionnaire, we found that symptoms only arose with negligible frequency. This can be explained by the fact that the prototype ran on a stable frame rate and was designed to be stationary, meaning that only the participants' actual head movements were translated into the VR experience, thereby reducing the mismatch between visual and vestibular information to a minimum. Also here we did not find any main effect of age on the results. Now, what are the kinds of developments and new technologies that we can expect in the future? One issue that has been a topic in virtual reality for a long time is the integration of haptic feedback. Some efforts like these haptic feedback gloves have been made. However, as of today, no consistent way to provide haptic information in the VR experience has been established. Other developments that are supposed to play a major role in the next generation of virtual reality headsets are the tracking and representation of facial expressions and gaze. This is supposed to make social interactions in VR feel more realistic and allow users to convey nonverbal information as well. While eye tracking is already possible in some VR headsets, the representation of gaze has not been made technically possible. This would allow users to make eye contact in virtual reality and communicate to other users what they are currently looking at. All of these developments are of course supposed to help the establishment of the metaverse, a virtual parallel universe that people will be able to enter with their VR devices. We'll see what the future will bring in this regard. Finally, I come to the topic of augmented reality and rehabilitation. Unfortunately, at the current moment, AR is only sporadically used for rehabilitation purposes, with most applications focusing on education and not rehabilitation itself. However, I want to show you a study from 2016 which used AR to treat phantom limb pain in patients who underwent amputation. In this video, you can see how the researchers gathered myoelectric signals from the patient's arm and converted that into a virtual representation of the amputated limb. Studies have found some evidence that the AR treatment of phantom limb pain might produce beneficial results. However, more large-scale research is needed to confirm these findings. And with that, I'm at the end of my presentation. Thank you very much for your attention. Questions and comments are always welcome, of course. And if you want to contact me in private, for example, to get a look at my references, please contact me via this email address. Thank you very much.
Okay, Lucas, thank you for a very clear and didactically well done talk. It was really a pleasure to listen to that. Let me have, there's one logistic question from the chat room, and far as it's possible to get access to the PowerPoints of the speakers. Basically, that is only possible if you contact the speakers directly. WFNR will make available the entire webinar, probably starting within, but usually takes 2 or 3 days before it becomes available, for a couple of weeks. So you can have a look again at that, but we are not authorized to send any PowerPoints or other material from the speakers to individual participants. Okay, let me first look. Okay, so let's open it to the panel. If there are questions from the panelists or the 4 of us at the moment. Not really. Lucas, let me come back to the issue. Yeah, what the hell is VR better than reality? There's nothing more real than reality, of course. But really, what are the aspects that make VR interesting and eventually usable for rehabilitation? What do you think is the most important point?
Well, as I said in my talk, there are a couple of relevant advantages that VR can bring to the table. I think what's really interesting for motor rehabilitation is the aspect that you can gamify the whole experience and make it just more interesting for the patient, more motivating. When it comes to the field of cognitive rehabilitation, which I talked about a little bit, it gets a little bit more difficult, because here it has the advantage over conventional computerized assessment tools or training tools, for example, that it just feels much more than reality and is a lot more ecologically valid than just sitting in front of a PC and training your attention this way.
I think that is probably the most important issue, and also from our experience for decades in rehabilitation, motivation is very much a very neglected field in this entire area. We have looked at brain plasticity, have looked at aspects of motor control, we've looked at aspects of cognitive organization and all of this, but we hardly ever systematically looked at the impact of motivation on what our patients are doing. And for me, it came up with the finding that we need very high intensity training to come across impairment-oriented rehabilitation, to come across proportional recovery rules and things like that. And yeah, nevertheless, motivation still is not very much addressed. not very much addressed on neurorehab meetings either. And we certainly have to work on this. There is, on the other side, there is a vast literature, psychological literature, on motivation, flow, and all of these aspects. And I think we have to embed that a little bit more into our day-by-day training and conceptual frameworks of neurorehabilitation. And VR may be very helpful in this respect, that's for sure. So let me look, any other questions or comments? There is one for Lucas from Valencia, Spain, and she said, well, but that's difficult to understand. Do you have experience with vaccination and VR?
I mentioned very briefly in the presentation that there's been VR applications designed for injection anxiety, especially for children. I put that under pain management, but it's also important if you want to distract people from something that is not that painful, but laden with anxiety. So it has been found that injection anxiety can be solved using a VR headset, that people at least don't think about it that much anymore.
Okay, well, that is clear. I think it's easily understandable. So at the moment, I don't see any more burning questions and no nasty, nice, or whatever comments. Sorry, I had to leave us some reasons. Igor, do you want to have a closing remark?
Yes, so there was a question that Lisa raised. Lisa Nur Hassana. I don't know if I pronounced properly your name. I apologize if I didn't.
Yeah.
So she asked how we could perhaps try to determine who would be a responder and who is not a responder for perhaps robotic therapy. So I can tell you we are finishing a paper. If you would let me, Homburg, I'm going to share a screen, just show a slide because that's the easiest. Then
I have.
Yeah, I cannot do that.
Christian can do that.
Christian, can you let me share a screen? I'll try again. If not, I'll use words. No, I still cannot. So, Lisa, there is, we did a study where what we look is that we look to 2 sequential therapy sessions. And what we are looking is how a person improves in a single session and how much they retain of that improvement the second time they come back using robotic metrics. And with that, we can predict quite well who is going to be a responder and who is not a responder. And we'll be able, like, you know, the paper is being submitted, but hopefully this will try to address your question. This is a very old idea from, you know, Homburg would like that because it's an old German person, Ebbinghaus, that had proposed that more than 100 years ago for us to look to the learning in the short term and long term. So what we do is that we see how much a person, as they are performing the robotic therapy, they improve in a single session. As they keep repeating the games, they keep improving, and how much they retain the next session they come back. So we are looking, essentially defining the capacity for them to improve and to retain the improvement. And we use this to predict the final outcome. And it's reasonable, quite good, the outcome. And hopefully that paper will be out and answer your question. That's it from my part, Homburg.
Igor, just one brief allusion to that. You know, robotics for a long time have been coupled with some sort of gamification, some sort of augmented reality. But my impression is most of the available products are not so elaborate on this. And I could imagine that linking, you know, the mechanical technology, the sensing technology, and the VR technology together would be very helpful, especially also when it comes to stabilize motivation in patients.
In case of motor rehabilitation, what we have seen is that when we make the games too complex, the patients actually get confused.
Sure.
So part of the reason why maybe the games are simple is because we started like, if I see the games that my son plays or I like to play, I still like to play games. They are like, very complex and very fast. And it can be too confusing for patients. So maybe that's why most gamification, most of the serious games that you see with robots are not so complex.
Okay, so as far as I can see at the moment, I don't see any further questions or comments. So let me thank the speakers again, and let me also thank our technological supporters, Christian and his team in particular. It was a good meeting. I hope you enjoyed it. In about a month's time, we will come up with the next webinar. We'll see what about. I don't tell anything about it so far. Okay, thank you very much. Have a nice rest of the day. See you soon. Thank you.
Thank you.
Thanks.